I was just checking if everything is working. So let's start. Good morning, everybody. I'm Sabeehah Vawda. I'm one of the clinical virologists at PathCare. And essentially, I've been asked to speak to you on human metapneumovirus. And obviously, the reason being that it is quite a trending topic. So it's all over the news because there's been a reported increase in the number of cases of human metapneumovirus in China. So, because it's just like 5 years since the discovery of SARS-CoV-2, there's understandably a lot of unease, and essentially people are anxious whether this is the start of a pandemic again, or whether this is a new virus as such. And obviously, the media is quite sensationalist with regards to this. So you see, these sort of glaring headlines stating things like new virus outbreak after COVID. This particular one states that 2 babies were infected somewhere in India, and the sort of statement then that goes with it is that there's no international travel history. And then this one from the US, which says little known respiratory virus. So just in terms of a background then, in the Northern Hemisphere, trends in acute respiratory infections do increase at this time of the year because it is the winter season. So these are typically caused by seasonal epidemics of various respiratory pathogens. So it's a seasonal influenza, respiratory syncytial virus, and then other common respiratory viruses such as the common coronaviruses, parainfluenza, rhinovirus, and obviously including human metapneumovirus. And then bacteria such as Mycoplasmoides pneumonia, which is actually the new name for the bacteria that was formerly referred to as Mycoplasma pneumonia. So a wide variety of circulating pathogens in the winter season that can actually result in respiratory infections. So many countries actually conduct routine surveillance for acute respiratory infections as well as the common respiratory pathogens. However, this is mainly sort of limited to influenza and its subtypes because that's the one of sort of prime importance. And most countries actually don't report on any of the other viruses, especially human metapneumovirus. So this is data from the WHO website, and it's essentially showing for the Northern Hemisphere the influenza that has been sort of circulating from it's October 2017 to 30th of December 2024. As you can see, there's been these sort of classic peaks that occurred 2018, 19, and 2020, followed by sort of a flattened graph. And that was obviously because of the emergence of SARS-CoV-2. And following all the sort of lockdowns and non-pharmaceutical measures and social distancing, etc., we noticed that there was a change in the seasonal pattern of influenza as well as other respiratory viruses. So you can see here there was a sort of a smaller dual peak that occurred in 2020, and then it sort of recovered in 2023 and 2024. So as you can see, not really human metapneumovirus data available widely from other countries in the Northern Hemisphere. Now, in terms of China, China has an established sentinel surveillance system for influenza-like illnesses and severe acute respiratory infections. And interestingly, their sort of sentinel surveillance system includes like just over 1,000 hospitals and healthcare sites. So it's a very extensive system. And they conduct routine virological surveillance for common respiratory pathogens, including human metapneumovirus, and they publish detailed reports of these weekly on the China CDC website. So at the end of December last year, the China CDC mentioned that they actually have a new system for monitoring of pneumonia of unknown causes. And they were actually going to pilot this new system. So it's a very high-tech system. They're going to pilot it and then roll it out nationally. So obviously, this is China being proactive, seeing that SARS-CoV-2 was also started off as a pneumonia of unknown cause. And so this is their sort of proactive way of trying to detect anything new or, strange as soon as possible. So China definitely has a very extensive surveillance and monitoring system in place. So according to the China CDC data that's available up until the 29th of December last year, there has been an increase in common acute respiratory infections, including those due to seasonal influenza, RSV, and human metapneumovirus. So influenza is currently the most reported cause of respiratory disease, and it's got the highest positivity rate in all age groups, except for the 5 to 14-year age group. And in that group, it's the Mycoplasmosis pneumonia that has the highest positivity. In terms of SARS-CoV-2, the activity seems to remain low. However, they have noted that there's been an increase in reported severe COVID-19 cases. The predominant circulating variant is XDV and its sublineages. So XDV is one of the recombinant SARS-CoV-2 viruses. It's a recombinant between Delta and Omicron. Then in terms of the current influenza-like illness activity, the southern provinces in China seem to remain below what was documented in the previous 2 years, while the northern provinces show that the levels of influenza-like activity is actually similar to what has been seen in the previous 2 years. So there doesn't seem to be anything strange there. The whole reported levels of acute respiratory infections, including human metapneumovirus, are within the expected range for the winter season, and there's no unusual outbreak patterns reported. The Chinese authorities have also confirmed that the healthcare system is not overwhelmed. So this follows reports in the media stating that, the hospitals were full and there was no place, etc. According to the official information from China, hospital utilization is currently lower than this time last year, and there have been no emergency declarations or responses triggered. Okay, so while we don't know particularly which sort of subclade of human metapneumovirus is circulating in China, the official information seems to mention that it's one of the sort of normal ones. So there's no hint of anything new being found. I tried to find, graphs from like official Chinese sites from the CDC to see if we could, compare human metapneumovirus activity to that found previously, but I struggled to find something like that. I suppose because everything's very sort of state controlled and official information like this is not easily available on the internet, and a lot of the information would be restricted to sort of the Chinese language, so searching in English doesn't really help. However, I did come across this graph, and it looks at distribution of human metapneumoviruses in a particular province, the Henan province in China, and this is extending from October 2017 to March 2023, and essentially, showing that human metapneumovirus has always circulated in China, and showing that there are particular periods of the year when normally they would have a peak in the circulation of the virus. Okay. So when was human metapneumovirus discovered? It was discovered in 2001 in the Netherlands, and these particular researchers were looking at respiratory infections, particularly sort of pneumonia in children, where there was no known cause, and they were trying to find the actual cause for it, and that's when they discovered this virus, and they designated it as human metapneumovirus. Upon testing historical samples, it was actually found that the virus was found worldwide and had been circulating in the human population for at least sort of 50 to 60 years prior to its actual discovery. So there's potentially two reasons why it took so long to find this particular virus. And one of the reasons would be that the symptoms that it causes are either sort of mild and very limited, or they sort of overlap with any of the other, respiratory infection viruses as such. So very similar symptoms, so not something that stands out in terms of the symptoms and signs. And then the second reason is that the human metapneumovirus apparently grows very, very slowly, and it's quite difficult to culture. So that could be two of the reasons why it was discovered only in 2001. In terms of the virus itself, it belongs to the family Pneumoviridae. So it used to belong to the Paramyxoviridae family of viruses, together with RSV. But then in sort of 2016, they were subdivided or moved around. So now it's a pneumoviridae family. So RSV remains a closely related virus, and you can consider it to be a cousin of human metapneumovirus. So in terms of the virus itself, these are large viruses. They've got an envelope. So remember, enveloped viruses are easier to sort of get rid of and be susceptible to temperature changes and chemicals, etc. The genome, it's a negative sense single-stranded RNA virus, and it's a non-segmented genome. In terms of phylogenetic analysis, there have been two subgroups identified, an A and a B, and there are two clades within each of these subgroups. So it's A1, A2, B1, and B2. Now, the circulating virus strains exhibit minor genetic diversity. So there's no evidence to date that any of the strains vary significantly in terms of virulence. So there was a large study done in South Korea that extended over 10 years, and they looked at all the positive human metapneumovirus cases, and they, sort of further identified which clade it was, but they didn't find any noticeable difference in terms of the clinical picture that was caused by any of the clades. So to date, we say that there's no difference in the clinical picture or the severity based on the clade that one is infected with. So in terms of the pathogenesis, obviously it's a respiratory virus, so it's inoculated within the nasopharyngeal mucosa, and then it spreads rapidly into the respiratory tract. The fusion glycoprotein is responsible for transmembrane fusion by binding to integrin alpha beta 1, which is one of the receptors that have been identified as being responsible for allowing entry into the epithelial cells. The virus then enters into the host cell cytoplasm. It starts undergoing replication, and this process then induces the response of various chemokines and cytokines such as interleukin-2, interleukin-6, and tumor necrosis factor alpha. And this leads to peribronchiolar and perivascular infiltration and inflammation. The inflammatory process also causes monocytes and lymphocytes to come within the airway endothelium, and all of this then leads to pulmonary inflammation, causing respiratory manifestations such as coughing and mucus production, wheezing, etc. So in terms of the transmission, the virus is a respiratory virus, so it's spread by droplets and large aerosols as well as fomites. So it's being in sort of close contact or direct contact with an infected person who's producing these droplets and large aerosols. It's not thought to be spread via small aerosols. In other words, it's not one of those viruses where if somebody has the infection within the room and then leaves, and if someone else comes in, it will still be sort of hanging around in the air and you could potentially get infected. It's not one of those. So it's more being in direct, close contact with an infected person. The incubation period is thought to be between 5 and 9 days, but it's not fully defined yet. In terms of the epidemiology, human metapneumovirus is ubiquitous, found everywhere. The global burden of infection is actually quite large. So worldwide, models estimate that there were 14.2 million human metapneumovirus associated cases of acute lower respiratory tract infection in children less than 5 years old in 2018. So quite a large burden of disease. It can cause both upper and lower respiratory tract infection in patients of all age groups, but the symptomatic disease most often occurs in young children, older adults, and it's the same age groups that would then be more likely to experience severe disease. So the virus does demonstrate seasonal variation. Obviously, this depends on data that's available. So as I said, most countries actually don't have monitoring systems for this and don't provide data on this. So from what's known, it seems that it usually circulates late winter and early spring, or late spring and summer. It did circulate at lower than expected levels during April 2020 to May 2021. And again, that was the result of the community measures and the non-pharmaceutical measures as a result of the SARS-CoV-2 pandemic. So in a study that looked at population-based burden estimates of respiratory viral infections in hospitalized patients, human metapneumovirus was found to account for 9.8% of infections, while rhinovirus was the sort of highest circulating one, accounting for 30.1% of cases. So looking specifically at the epidemiology in children, first infections occur early in life. So data suggests that essentially everyone is infected by the time they are 5 years old. Younger age may be associated with human metapneumovirus disease that requires hospitalization. And studies have shown that a history of prematurity is actually a risk factor for hospitalization once infected with human metapneumovirus. The virus can cause fatal respiratory illness in very young children. In terms of the epidemiology in adults, so it results in mostly an upper respiratory tract infection. It's considered to be a less frequent cause of lower respiratory tract infection. According to USA data, it's been detected in approximately 4% of hospitalized adults with community-acquired pneumonia, primarily as a single pathogen, but co-infection with other pathogens was also common. Frail, older adult patients are more likely to require medical care and more likely to end up in hospital. And then importantly, it has been detected from asymptomatic individuals. So again, that potential for spread to immune-compromised populations. In terms of the clinical picture, it's usually associated with a mild self-limited respiratory infection in children and adults. So I've tabulated the typical cause of mild disease and severe disease. So both diseases would sort of start off with an asymptomatic period that lasts for a few days after inoculation. In a cause of mild disease, the patient would experience a week or so of upper respiratory tract symptoms, and then there's this gradual resolution. In severe disease, there's 1 to 2 days of upper respiratory tract symptoms, and then it quickly progresses to wheezing and or other signs of lower respiratory tract involvement. And then the wheezing can last for a few days, but in patients that have reactive airway disease, sort of an underlying condition, this wheezing and coughing can actually last for a few weeks. So it can be, quite a prolonged cause of disease. In terms of patients that require hospitalization, their clinical picture ranges from bronchiolitis or asthma exacerbation to severe pneumonia and acute respiratory distress syndrome. So looking specifically at the clinical picture in children, so these are the common symptoms that were described in a large surveillance study of kiddies that were infected with human metapneumovirus. You can see cough is quite prominent, and so is fever. And then obviously others like a rhinopharyngitis as well as a laryngitis. In terms of lower respiratory tract infections, bronchiolitis accounted for sort of 59% of cases, and bronchiolitis together with pneumonia were the main causes of hospitalization in this cohort of children. The disease severity may be increased with RSV co-infection, and it's unknown if primary human metapneumovirus infection that is very severe or if it occurs very early on in life will then predispose that child to asthma or a higher frequency of subsequent wheezing-associated respiratory illnesses. So there have been some reports, but obviously no sort of definitive overview of it. In terms of adults, again, these are the symptoms that were commonly described in a large surveillance study of adults infected with human metapneumovirus. Essentially, everybody had a cough. The dyspnea and wheezing tends to occur more in the elderly, more older adults, and then the hoarseness tends to occur more in younger adults. The clinical features of human metapneumovirus pneumonia are similar to pneumonia caused by other pathogens, so you can't differentiate clinically. And a possible role in COPD and asthma exacerbations has been described, but this is controversial because there have been sort of conflicting reports from different studies. Recurrent infections are common. The reinfections do appear to be mild, although immune-compromised patients may be at a risk of severe disease. So remember, essentially everybody has been infected in childhood. So any infection that occurs in an adult is essentially a reinfection that is occurring. So immune-compromised hosts, they appear to acquire the infection as the same frequency as immune-competent individuals, but the infections are often more severe and the course may be more prolonged in the immune-compromised population because of poor clearance of the virus after infection. So in a large South African study that included both children and adults, a higher incidence of human metapneumovirus-associated hospitalization was noted in the HIV-infected individuals compared to those that were HIV uninfected. And then a high burden of human metapneumovirus infections have been reported in a retrospective study of children and adults with cancer, and that's especially hematological malignancies. And it was found that these patients were more likely to need ICU level of care, and they actually have a higher mortality than the otherwise healthy individuals. Lung transplant patients are also susceptible to severe human metapneumovirus disease. So in terms of the diagnosis, the most sensitive and the sort of quickest way of diagnosing human metapneumovirus would involve, doing a reverse transcriptase PCR. So at PathCare, these are the assays, multiplex assays that would include human metapneumovirus in them. So it's the BioFire respiratory panel, the BioFire pneumonia panel, as well as our sort of normal respiratory viral PCR panel. And this sort of test would be similar to that's found at other private labs as well as in the public sector. So there are other testing methods that have been described or can be used, but a lot of these are sort of restricted to research settings. In terms of serology, the antibody testing is used in epidemiology studies and vaccine research settings. Antigen testing is available in the form of like a rapid detection kits. But as far as I know, the sensitivity has not been great, so I'm not aware of it being available very widely. And I don't know of its availability in South Africa at all. In terms of imaging, chest X-ray findings are generally non-specific. So there would be sort of, hyperinflation and sort of less consolidation, but nothing very specific that would help to distinguish it from other forms of pneumonia. And peripheral blood counts, the white cell counts and percentages tend to be non-specific. So treatment, like most viruses overall, there are no available antivirals that you can use to treat human metapneumovirus. Ribavirin has been shown to exhibit some in vitro antiviral activity against human metapneumovirus, but there hasn't been sort of large clinical studies that have confirmed this. There have been case reports where ribavirin has been used successfully, but again, there's no large clinical studies that have been conducted. So in terms of the treatment, it's mainly supportive, and it would vary with the clinical manifestation. So that would include the use of steroids in various forms, especially for patients that have severe wheezing. The rate of secondary bacterial lung infection or bacteremia in patients with human metapneumovirus has not been defined, but it's thought to be low. So in terms of prevention, the basic sort of preventative measures apply as for any other respiratory virus, and sort of coming out from the COVID pandemic, we all are quite aware of this. So it's hand hygiene, and then maintaining a physical distance, donning a mask when one is ill, essentially staying at home when someone is ill. In terms of IPC, suspected or confirmed human metapneumovirus infection cases, contact and droplet precautions need to be implemented, and hospitalized patients should ideally be nursed in a single room or cohorted. And prolonged shedding has been noted in children, like lasting days to even weeks. So children are sort of considered safe to return to daycare or school once acute illness has resolved. But immune-compromised patients are advised to actually avoid contact with children who have had human metapneumovirus during the acute phase, obviously, but also during the early convalescence phase because of this supposed prolonged shedding of the virus. Then in terms of vaccines, live and subunit experimental vaccine candidates are in preclinical development. And in July 2024, the University of Oxford launched a phase 1 study to test an investigational mRNA vaccine developed by Moderna for both RSV and human metapneumovirus. So it's the first time that a vaccine has actually been developed to sort of simultaneously protect against both RSV and human metapneumovirus. So it'll be quite interesting to see how the vaccine fares and whether it actually, qualifies to move on in terms of development. Okay, so what is the risk to South Africa? Because there's a lot of concern about this new virus that's in China. So firstly, human metapneumovirus, as I've mentioned, it's not a new virus. And in South Africa, like the rest of the world, it's detected all year round as one of the regular seasonal respiratory viruses. Based on a risk assessment tool for South Africa, the NICD has concluded that the risk of importing respiratory illnesses from China is actually low. The NICD is continuously monitoring local data for any changes in disease patterns, and in the case of an outbreak, NICD and the private laboratories all have the capacity to test. The testing, platforms are already in place, which is different from what happened when COVID was discovered, because that was totally new. Then, interestingly, in August 2024, the Department of Health, with the various stakeholders, convened in Joburg to participate in the tabletop simulation exercise in order to test and refine a draft of the National Respiratory Pathogen Pandemic Plan. So this is something that the DOH and stakeholders are putting in place in order to test or to be, to test the responsiveness of various healthcare settings to a potential new virus. Okay, so then just to end off, I thought I'd share some PathCare data, and Prof. Nikki kindly pulled the data for me from PathCare. So this is just PathCare data for 2022. It doesn't involve any other labs. And as you can see, the human metapneumovirus is the one in green, and found at low levels throughout the year, with the peak at about 10% noted roughly between sort of July and October. And then this is the 2023 and 2024 data. So again, in 2023 and 2024, circulating at low levels throughout the year. But then there's that peak that occurs between sort of May and October, or June and November. As you can see, in 2024, we had a higher peak than what was described in the previous 2 years. So it rose to just about 18%. So in conclusion, to date, there's no unusual increase in respiratory infections, including human metapneumovirus in China. According to the official information that's available from both the WHO and the China CDC, there's no detection of any new virus at this stage, and the human metapneumovirus also appears to be one of the usual circulating strains. The WHO and China CDC are monitoring the situation. So obviously it's an evolving situation. So we'll just have to monitor and see where this actually goes. There is currently no need for any travel restrictions because human metapneumovirus is found worldwide and it's considered to be a normal seasonal virus. In South Africa, the NICD is closely monitoring the situation, and important to remember that the labs actually do have the testing capacity, and it's already included in our multiplex respiratory assays. Okay, thank you. So that's all that I had to say, and these are the references, and if there's any sort of other questions, then you're welcome to contact me via PathCare Laboratories.